This talk is an introduction to talus fractures. I'm just going to turn off my video here. These are the learning objectives for the talk. So we'll discuss first the blood supply to the talus and the issues that poses for clinical outcome from talus fractures. We'll talk about the Hawkins Classification system and what it predicts with regard to clinical outcomes. And then we'll talk about the principles of treatment, and the kind of key messages with treatment are: number one, that reduction of a talar neck fracture dislocation is an emergency, but definitive fixation is not. We'll talk about the surgical approaches, and the key message there is that 2 approaches are required for anatomic reduction of a talar neck fracture. And then the third principle of treatment is that for fractures involving the talar body, the go-to option is a medial malleolar osteotomy. And then the last point that's not really related to talar neck is just we'll talk very briefly about lateral process of talus fractures, which are a unique entity. So a little background on talus fractures. The talar neck fractures typically occur from forced dorsiflexion of the ankle. Was originally recognized during World War I when some planes were crashing, and I guess their aviators' feet would jam into the pedals that they used to fly the airplane, and they would fracture their talus. And the talus in Greek is called the astragalus, so thus was coined aviators astragalus. In modern times, now these are typically occurring either falls from height or more commonly motor vehicle crashes. But they remain relatively rare, just a very tiny fraction of overall fractures. When their talus fractures do occur, about 50% involve the talar neck as the most common location. Just worth noting that the talus is articulates with several other bones, and those joints are very mobile and very critical to foot and ankle function. So the first is the tibio-talar joint, the ankle joint. Below the talus is the subtalar joint, and then anteriorly is the talonavicular joint. Of course, the ankle joint involved in dorsiflexion, plantar flexion, and then the subtalar joint and talonavicular joint work together to do inversion and eversion, supination, pronation of the foot. So what that means is that the talus, because it has so many articulations, is covered by cartilage, 60 to 70%. And because there's so much cartilage, there's not a lot of room for blood flow to get into the talus, and that's why talus fractures are associated with osteonecrosis. The other reason why it's relevant is that if there is any displacement of the talus, whether at the talar neck or elsewhere, it's going to alter the mechanics of these joints. You're going to be changing the relationship either because it directly enters the cartilage of the ankle joint or the subtalar joint, or because just the relationship between the talonavicular joint and the subtalar joint and its multiple facets is going to be altered, and that is why talar neck fractures are associated with the high rate of post-traumatic arthritis as well. And so these fractures are, the goal is always an anatomic reduction when there's any degree of displacement. The classification system, we'll talk about this Hawkins in a second, but before you get to Hawkins really is a classification for talar neck fractures. There are other fractures that occur in the talus. We generally just go by a descriptive classification based on the anatomic location of the fracture. So the talus has a body posteriorly, which has the ankle joint and the posterior facet of talus on it. And then anteriorly, it has the talar head, and between the head and the body are the neck. So each one of those areas can become fractured. And then you'll see here also the lateral aspect of the talus, there's this prominence, which is the lateral process of the talus, which can also fracture. And then there's a posterior process as well that can become fractured. So the first describing a talus fracture, you just want to describe initially where it is a talar body fracture, talar neck fracture, or a process fracture. And that's kind of the first step. We talked a bit about blood supply already. You really have to understand how important this is. There's really blood supply to the talus from all three major vessels that supply the foot. But the most important blood supply comes from posteriorly. At least the most important blood supply to the talar body comes from the posterior tibial artery. And there are a couple of major branches. One is the deltoid branch, and the other is the artery of the tarsal canal. And those two branches of the posterior tibial artery supply most of the talar body. So if that gets disrupted, and there's a talar neck fracture that's going to disrupt any of that retrograde blood flow, then that's when the risk of AVN goes up. In terms of imaging of the talus, you're going to get your standard views of both the foot and the ankle. So the AP mortis and lateral of the ankle, as well as AP oblique and lateral of the foot. Obviously, the lateral of the foot and ankle are the same view, but it's 5 views typically to fully evaluate the talus. In addition to that, those standard views, there is a special view for the talar neck called the Canale view, which we'll talk about in a second. It's shown here in this picture. It's sort of a variation on the oblique view. And then third is CT scan. We almost, the Canale view has largely been made obsolete because of the wide availability of CT scanning. So now most of the time we don't, in the ER at least, take the time to get a Canale view. We just go right to the CT scan. But I think it's still important to understand the principle of the Canale view and what it can show you. So this is a couple of images that show a regular AP foot versus a Canale view. And what you can see is that on this regular AP foot, I mean, I can outline the talar neck here, but it's a little bit difficult to see. There's a lot of overlap with the calcaneus, so it's a lot less clear. On the right image, which is the Canale view, you can see that with just that bit of obliquity, you get this nice profile view of the talar neck. So particularly before CT scans were available, if you wanted to diagnose a minimally displaced or slightly displaced talar neck fracture, this is a really critical view. But now that we have CT scans, and if we have any suspicion, we're probably gonna get a CT of the foot, it's probably a little bit less useful. Still can use it. I use it if I'm non-operatively treating a non-displaced or minimally displaced talar neck fracture. I'll still use it to assess healing and follow-up because you can't just get CT scans. There's also some utility in using it intraoperatively to assess your reduction, things like that. Again, the main idea is you're just taking away that overlap between the talus and the calcaneus. So the Hawkins Classification is one of the most, more famous orthopedic classification systems. And it guides treatment, and it also is highly informative for prognosis. The type 1 talar neck, Hawkins type 1 is a non-displaced talar neck fracture. So these are the ones that you may barely see on a plain x-ray, and I'll see better characterized on a CT scan. This is the only one that really there's any consideration for non-operative treatment. But if it's truly non-displaced, you can treat it in a cast. There is also some debate about, doing percutaneous fixation even for these non-displaced ones, just to prevent displacement, because it's so catastrophic if it does happen. And also this allows early motion. So for not type 1s, sort of non-operative treatment or percutaneous fixation are an option if you want to allow early motion and reduce risk of secondary displacement. Type 2 talar neck fractures are those that have a displaced talar neck fracture associated with subtalar subluxation or dislocation, which is, it turns out, describes actually a huge spectrum of injury, because if you think about it, if the talar head stays fixed and you begin to displace the talar neck, any amount of displacement is going to begin to create subluxation of the subtalar joint. In other words, you can't have a displaced talar neck without subluxation of the subtalar joint, assuming that the head remains located. So you have anything from a displacement of 1 millimeter or 2 with very minimal slight subluxation, all the way up to a complete subtalar dislocation. So the key point there is just that these ones, there's quite a bit of spectrum here, and so there's even been suggested that we should subclassify these into type 2A and type 2B. Type 2A are just the subluxations, type 2B are the dislocations. And it turns out if you classify that way, then the type 2Bs, type 2As behave a lot like a type 1 in terms of the risk of AVN and the risk of other complications, whereas the type 2Bs that are actually dislocated, they behave a lot more like a type 3 or a type 4 with higher risk of AVN and other complications. So it's kind of a useful classification. It's also useful because if you have a dislocation, you need to urgently reduce it, whereas if you have just a subluxation, you may not need to do anything emergently. The type 3 talar neck fracture involves a dislocation of both the subtalar and the ankle joint. It means that the talar body is essentially extruded. It's worth noting that with these type 2 and type 3 fractures, the talar head is staying where it belongs with the talonavicular joint, and the body is what's moving. The body is what's dislocating. So in this case, it's dislocated both from the ankle joint and the subtalar joint. These are obviously an emergency to get reduced. And then the type 4, that was the original Hawkins classification, was just type 1, 2, 3. And then the type 4 was a modification where the body is dislocated from the ankle and the subtalar joint, and the talar head is dislocated from the talonavicular joint. So it's sort of everything's dislocated. These are really, really rare, but they do exist. There are also variants where the body stays put and the head goes, and those don't really fit in the classification system, but just worth understanding what is actually what's staying home and what is actually dislocating. And usually it's the talar body, 90+% of the time. So these injuries have a high risk of complications. The main ones, and this used to show up on the OIT, I don't know if it still does, but the main complications are osteonecrosis, which results because of that tenuous blood supply, and then arthritis, which can involve the subtalar joint or the ankle joint. And the rates of those two complications, arthritis and osteonecrosis, goes up as you go up to increasing Hawkins classification. And again, the cut point, it really happens when there becomes a dislocation. So if you have the Hawkins 2A with no subluxation, with only subluxation, no dislocation, relatively low risk of these complications. If you're a type 2, though, that has a dislocation of the subtalar joint, then now these complications go up substantially. So that would be the Hawkins 2B. So I've alluded to this already as we've gone through the classification system, but the management, the first big, sort of question or controversies around timing of treatment, just like the femoral neck or other bones that are at risk of osteonecrosis, timing is an area of controversy. The general consensus with the talar neck is that as long as you reduce the dislocated joints, then you don't have to do the definitive surgery immediately. For example, patient comes in with a Hawkins type 3 talar neck fracture, body is extruded. You've got to get that reduced emergently. So you can try to do it with closed reduction in the emergency department, But if that's unsuccessful, then you have to be coming in the middle of the night and getting the body reduced as soon as possible. And that time to reduction is associated with osteonecrosis. Once you get it reduced, you know, if the ankle is really swollen or it's 2 in the morning and it's a really complex fracture, it's okay to either splint if it's stable or X-fix if you need to, and then allow the soft tissue swelling to subside and do the definitive surgery when, you know, you have the soft tissue swelling subsided and you have the time and the resources to make it perfect. So emergent reduction, definitive fixation when the soft tissues allow. The approach to talar neck fractures, the workhorse is a dual incision anteromedial and anterolateral approaches. So that's another kind of key message of the talk. To reduce the talar neck, you can't do it from one side. And the reason is that the tendency is to close down the one side. Say that if you approach just from medial, you'll close down the medial side, then the lateral side will gap. And the same in reverse. So you've got to see both sides of it so you don't create a malunion situation. The second kind of key point on approach is that if the fracture extends back into the talar body, and you can see, you know, the neck body junction and even maybe the anterior third of the talar body through with plantar flexion of the ankle. But if you have a more central body fracture, you almost invariably, if it's displaced and you need to reduce it, you have to do an osteotomy. You know, we tend to do the medial malleolar osteotomy. Most of the time it's a lot more straightforward. You don't disrupt the syndesmosis the way you would with a lateral osteotomy. But you know that you can do lateral osteotomies as well, but the workhorse, like gold standard, for the vast majority is going to be a medial malleolar osteotomy. So we'll go through each of the approaches a little bit. The anterolateral approach is pretty straightforward. It's proximally midway between the tibial crest and the fibula. Distally extends in line with the fourth ray. You come down, you open up the extensor retinaculum, the extrinsic muscles, tendons of the anterior compartment, they all get retracted medially, and then your intrinsic muscles, you know, which originate off the calcaneus, those are kind of going to get retracted plantarly. So there's a little bit of an interval there between the extrinsic and the intrinsic muscles. But you get a pretty nice exposure of the talus using that approach that you can apply plates and insert screws through fairly comfortably. The medial approach, it's described as being midway between the anterior tib and the posterior tib. So your landmarks, you can use the medial malleolus and the navicular tuberosity. You can, you know, depending on how dorsal or plantar you want to be, you can cheat the incision up or down. And it's a pretty boring approach. I mean, you size the skin, you make sure you identify and protect the saphenous vein, and then you're basically just on capsule and open up the capsule and get onto the neck. What you see here, and there's a little blue arrow pointing, is, you know, you don't have a lot of real estate that's not cartilage from this approach. So that makes it a little bit more challenging compared to the lateral side. There's not a lot of real estate to put plates in, so we're often doing using screws through this approach that are, you know, countersunk through the talar head, which we can talk a bit more about in a second. This approach, what's nice, you can just extend the skin incision proximally, and then you can do a medial malleolar osteotomy. The third image over there is just sort of showing you go to pre-drill your screws. You can pre-drill and tap even, and then do your osteotomy. Usually, you know, cut with a blade initially up to the subchondral bone, and then complete it with an osteotome, so you don't have a blade kerf at the cartilage level. That gives you the access. You see here on the right, you can see it's like a talar body fracture with a bunch of wires in it, which you could never do with the medial malleolus in place. So you fix it and then close it back up. what's key here to think about is number one is the bone is blocking your view of the talar body. But number two is like you could say, well, why don't we just extend back and cut the deltoid? But remember the blood supply. If you start cutting through the deltoid back there, you're going to be potentially disrupting whatever blood supply that talar body has left. So what's a real positive about the medial malleolar osteotomy is that it does not disrupt the blood supply to the talus any further than the injury already has. So, you're going to use your dual approaches. You're going to get the bone reduced, and then how are you going to definitively stabilize it? Well, typically with some combination of either screws or mini fragment plates. The screws can be positional screws or lag screws, depending on the combination. It turns out that plate fixation is a lot easier on the lateral side, just because you have a lot more space. You can see a lot more talus through that approach, and so you can do a little bit more. You can kind of get that sense on this bottom right image here. This is one where I actually plated both sides, but there's just on the lateral side over here, you have it's like a 5 or 6 hole T plate. You get quite a bit of fixation. Whereas on the medial side, it's this short little plate, like 3 or 4 holes, and you're coming up really close to being into the ankle joint. So it's a little bit much more difficult to put plates on the medial side. What we often do is we'll do a plate on the lateral side, and then you can do some screws on the medial side, which you can counter. Basically, you put the plate on the lateral side, then you can abduct the foot. I'll draw a little bit here just to show. So you put your plate here on the lateral side, which is going to be kind of your provisional, fixation. That's going to allow you to take the foot and abduct it over this way, which is going to give you a little bit more exposure of the talar head. And then you can put screws in countersunk in the talar head going back into the body this way, which I'm showing in yellow there. So you have your lateral plate first, then abduct the foot, and then put in your countersunk screws. The screws are usually a 3/5 size. Sometimes you could use 2/7 as well if you don't have a lot of real estate. The mini frag plates are usually like a 2/0, 2/4 size. So I gotta get rid of my animations here. So we talked about the Hawkins classification. There's both a Hawkins classification and a Hawkins sign. The Hawkins sign is I don't know, it's always like counterintuitive to me, but it's a lucency in the talar, just below the subchondral bone of the talar body that you see typically 6 or 8 weeks after surgery. This is patient of mine. Here he is. See this little loosened area, like right in the center of the talus, right there. That's the Hawkins sign, and it's not a bad thing. It's a good thing, because in order to resorb bone, you have to have blood flow. If you don't have blood flow, then what you'll see instead of that nice loosened area is you'll see kind of chalky, sclerotic looking bone, and that's what avascular necrosis looks like. So that's what we hope not to see. It's not always this, it's not always totally clear, but the bottom line is you don't want to see a chalky looking talus, because that's a one that has not revascularized. So that's kind of the main things on talar neck fractures. This is a 20-year-old snowboarder diagnosed with an ankle sprain. He comes in and he's still got pain. What's the diagnosis? Well, what I'm trying to get at is that he's got a little lateral process fracture here. You can see it on the AP. You can kind of pick out that there's something going on as well there on the lateral view. This is the lateral process, and it's it's this sharp angle that you get on the lateral view. And so you always want to scrutinize that in a patient who has an ankle sprain, that and make sure that they don't actually have a fracture. This is often called a snowboarder's fracture because they're particularly prone to this particular injury. Typically, once we have suspicion for it on the x-ray, we'll get a CT scan to better characterize it. And they kind of come in like 3 flavors. They can be just completely non-displaced, which you can treat conservatively. They can be really small, in which case you probably always would also treat them conservatively. But if they're large and have any amount of displacement, then generally we treat them operatively. You can treat it through a sinus tarsi tight style incision, sort of extending from the tip of the fibula distally. Will put you right down on the lateral process there. My incision's a little bigger than the one usually than the one shown in this picture here, but you get the idea. It's not a huge open exposure, but you do need to be able to see enough. This is just this case of mine where I just put a little mini fragment plate, sort of buttressing that piece down, goes on to heal uneventfully that way. But the key is you don't want to miss it, because if you miss the diagnosis, they can get a non-union, and then they can develop post-traumatic arthritis of their subtalar joint and things like that, and do much better if you identify it early and treat it surgically and get it to heal. So that's all I have for the talus talk. The take-home points: be sure to understand that blood supply to the talus. Remember, it's the posterior blood supply that's sort of the dominant blood supply through the artery of the tarsal canal and the deltoid branch. Know the Hawkins classification, type 1, 2, 3, 4, and that it predicts with increasing Hawkins grade, you get higher rates of osteonecrosis and post-traumatic arthritis. Remember that in terms of timing, reduction is an emergency. So if you have a subtalar or tibiotalar or talonavicular dislocation, it has to be emergently reduced. You can attempt that in the emergency department, but if you're unsuccessful, you got to book the case and go to the OR and take care of that reduction in the middle of the night. What you're not obligated to do in the middle of the night is you don't have to do the definitive fixation, particularly if the soft tissue swelling is not ready for it. And so you can, as long as you get it reduced, then you can wait and do definitive fixation at a later date. That delay in definitive fixation, as long as it's reduced, has not been associated with osteonecrosis. Remember that if you're going to fix a talar neck, you have to use 2 approaches. You can't adequately assess the reduction from one side. You must see both sides. Third key treatment thing for talar necks, or those that involve the body, is that if you need extension to see more of the talar dome, then you can do a medial malleolar osteotomy, which preserves that deltoid blood supply. And then finally, it's kind of a different flavor of patient than a talar neck fracture, but remember these lateral process fractures, snowboarders fractures that are commonly missed. Make sure you scrutinize the lateral process on both AP and lateral views on any patient who has been diagnosed with an ankle sprain. Thank you.